I want to talk about some of the drugs for depression and for mania. I was going to do that in a nicer part of my garden, but there were a million spiders there and I don't like spiders, so sorry. At the heart of all drugs aimed towards treating depression or mania is the monoamine hypothesis. And that hypothesis is that neurotransmitters that are monoamines, meaning they have one amine group on them, chemically speaking, and that would be dopamine, norepinephrine, and serotonin, that low levels of these neurotransmitters cause depression and high levels of these neurotransmitters cause mania. So if you can remember that too little is depression, too much is mania, you're 90% of the way there. Now, a few comments about all the drugs that are for depression. That's where we're going to start. The drugs that are used to treat depression, all the ones that are currently approved for depression, take 2 to 3 weeks to start working. So if a patient is quite depressed, you start them on a treatment, and a week later they're suicidally depressed. That doesn't mean you need to change drugs. It means they probably need to be in the hospital, but you haven't given that drug a chance to start working. So that's important to know. The other thing is that, as I mentioned the first day of class, the black box warning for a lot of the antidepressants stem from a study done with SSRIs in which adolescents with depression took surveys every day as to their level of depression while they were taking these drugs, and around day 7 to 10, many adolescents said that they were thinking more about death and suicide. It wasn't that they were actually committing suicide, it's that they were thinking more about death and suicide. And so the black box warning was put on that for depressed patients that are adolescents, young adults, you need to warn the patient and their family that they might have an increased thoughts about suicide at that point. It's a good idea anyway with adolescents to make sure that somebody's helping them, watching them when they're first starting to take their medications. Another thing to be aware of is that if a patient states that they are feeling suicidal or they want to kill themselves, that means that that patient needs to be evaluated in an emergency room or by a psychiatrist for their risk of suicide. That would be an indication for hospitalization. Now, one of the ways you can quickly determine if a patient is actively suicidal is to ask if they have a plan. So patients that actually have a plan for how they're going to carry out their suicide are at much higher risk for suicide than ones that then somebody might just say, oh, I have a test tomorrow, I'm going to kill myself. That's a different situation. So whenever in a situation with a person that's talking about suicide, you need to get them to a medical professional, and in emergency rooms there are psychiatrists on call 24 hours a day, so that if a patient is at risk for suicide, they can be evaluated to see if they need to be hospitalized. Okay, all right, so let's talk about some of the drugs that are used as antidepressants. Now, one of the oldest drugs they were starting to be used for depression in, I think, the 40s or 50s, was the monoamine oxidase inhibitors. So we'll start with the oldest drug and we'll move towards the newer drugs for depression. So the monoamine oxidase inhibitors, we've talked about them before. They are indirect acting sympathetic agonist drugs because the monoamine oxidase inhibitors, especially the older ones, work to inhibit monoamine oxidase, the enzyme that breaks down norepinephrine and serotonin. So the mechanism of action is by indirectly increasing those neurotransmitters. That helps to elevate the mood of a depressed person. Our prototype MAOI is nardil or phenelzine. Now, the problems with the MAOI are numerous. Number one is you cannot combine MAOIs with any drugs that have sympathetic activity. So that would include the stimulant drugs that we talked about for ADHD, as well as, remember, alpha-1 agonists. You don't want to give a sympathetic drug in addition to the MAOI because you can have this enormous blast up of blood pressure, and that can cause a stroke and other problems. Any drug that's going to be used as an antidepressant is going to, by its nature, increase monoamines like norepinephrine and serotonin. So you want to be very careful using those. In fact, the drug interaction with monoamine oxidase inhibitors, or MAOIs, the drug interactions are so severe that if you have a patient maybe who tried an antidepressant and it failed and you want to try them on a MAOI, you have to stop that other drug for maybe 2 weeks to make sure it's completely out of their bloodstream, and then you start the MAOI, and then of course you have to wait 2 or 3 weeks to see if the MAOI works, and then if that doesn't work and you want to try a different antidepressant, you have to stop that MAOI, wait for it to get out of the system, a couple of weeks, and then start a new drug. So taking an MAOI for depression involves several weeks of not being on any antidepressants at all for a little while, then being on the MAOI, hopefully it works. If it doesn't work, then you have another window where you can't be taking any medications until you can start another one. So that alone is misery enough to not want to use those drugs. Additionally, there's tremendous dietary restrictions when you are given MAOIs because of tyramine that is found in foods. Tyramine can also lead to this huge stimulation of blood pressure. On a restricted diet for MAOI, I just remember them as foods that you would get in a fondue restaurant. So there's a lot of different ones, but just 3 that you can remember would be wine, cheese, and chocolate, right? And I always think, oh, it's bad enough you're depressed, now you can't have chocolate, oh my God. And if you're in Wisconsin, of course, being deprived of cheese is, the worst thing possible. Sorry, Wisconsin. All right, next category of drugs would be TCAs, or tricyclic antidepressants. There's also tetracyclic antidepressants, and some people call this class of drugs cyclic antidepressants. The cyclic part comes from a structure within the chemistry of the molecule itself. TCAs tend to have similar endings, like triptyline, like nortriptyline, or amitriptyline, so that helps you sort of know that drug class if you can recognize that ending. The mechanism of action of the TCAs is not as fully understood, but the TCAs increase norepinephrine and serotonin levels for sure. They also have some histamine effects. They've got a lot of different effects. So these drugs are used as antidepressants. They're also used for a number of other indications, including enuresis, which you'll remember is the medical term for bedwetting. They're also used for chronic pain. I have a friend who is a musician who gets a lot of jaw pain, and for a while was on an amitriptyline. I take nortriptyline myself for my vestibular migraine. So good for pain, good for other things. Now, at this point, I have to make a comment about something which I've been trying to avoid until now, which is that we talked about in the autonomic nervous system, we talked about the anticholinergic drugs, right? Like atropine, things with trope in them, atropine, benztropine, ipratropium, those kind of drugs. In medical, like health speak, when you talk about certain drugs having anticholinergic side effects, that doesn't necessarily mean that the drug blocks the acetylcholine receptor. So it's just a shorthand way of saying that a drug has side effects similar to those of anticholinergic drugs. So dry mouth, constipation, reduction of urinary flow, worsening of symptoms for patients with glaucoma, or obviously with big prostates. So just be aware of that. I think this is a nice drug class to introduce that with. So the TCAs, or the cyclic drugs that are antidepressants, have anticholinergic side effects. So just to be aware of that, that's an inexact term that's used a lot in the health community, and you should just know about it. Doesn't necessarily mean that it's pharmacologically an anticholinergic. One last thing to say about the TCAs is that they tend to have very low therapeutic indices. So when a drug has a lower TI, that means that that's a drug that you're probably going to be getting blood levels, drawn on those patients to be sure that the levels aren't too high and become toxic. A drug with a low therapeutic index, you also probably want to not switch from trade to generic and back again. It's fine to be on a generic version of the drug, but just be sure you're on the same generic version, because there's a variety of companies that make generic versions of various drugs. Because again, just a small change in the formulation might increase or decrease the level of that medication. Now, additionally, because of the low therapeutic index, you probably want to be careful giving this drug to a patient that is suicidally depressed. As you'll recall from the DSM-5 criteria for depression and the ones that were mentioned in the other video I had you watch, you don't have to be suicidally depressed to have depression. A lot of nursing home patients initially were thought to be demented, turned out to just be depressed, because depression can also bring down cognitive function, right? So there's sort of slower thinking and anhedonia and weight change and other symptoms that can be related to depression. But if they're at some risk for suicide, you probably want to be careful not to give them a 90-day supply of a drug that has a very low therapeutic index. Right? I mean, that should make sense, because you don't want to give them an easy way to commit suicide. Much newer drug class is the selective serotonin reuptake inhibitors, or the SSRIs. Now, every year on the final, I either have SSRIs or ACE inhibitors or something like that, and I ask, what's the mechanism of action? The mechanism of action of selective serotonin reuptake inhibitors is that they selectively inhibit the reuptake of serotonin. It's not a trick. The name tells you what it does. So this is an indirect acting drug class. It's inhibiting the reuptake of that neurotransmitter and increasing the level of that neurotransmitter in between the synapses and the nerves. Okay, so that's not direct acting, it's indirect acting. All right, so SSRIs selectively inhibit reuptake of serotonin, and so they cause an increase in serotonin levels, and that seems to mediate the effect of the return of mood for patients with depression. I should mention that, all these antidepressants, none of them make you abnormally happy. In other words, a patient who's depressed, who's on an SSRI, it's not going to make them high or euphoric or manic unless they are actually an undiagnosed bipolar patient. It just brings them back to normal. In the same way that aspirin reduces fever, right? But if a person with normal temperature takes aspirin, their temperature doesn't go down, right? It just normalizes their temperature. And the same thing holds true here for the antidepressants. The idea is that you're normalizing the mood, not making the person abnormally happy. And in fact, there's no better proof than the fact that antidepressants are not black market drugs. People don't take them, don't abuse them, because they don't make you high. They just bring you back to normal. Okay. We mentioned some of the SSRIs when we talked about anxiety drugs, because again, I think of serotonin as making you content, right? It's contentment, right? So they help reduce anxiety as well as lifting mood in patients with depression. Right, so some examples of this drug include paroxetine, which is Paxil, citrulline, which is Zoloft, fluoxetine, which is Prozac. So notice those all end with zetine. That helps you remember that that's going to be some kind of neurotransmitter reuptake inhibitor drug. Okay, that's that. There's also a few that end with pram, like Celexa and Lexapro, which is citalopram and escitalopram. They're sort of two different versions of the same molecule. A lot of the SSRIs, unfortunately, reduce libido, which is not great. Some of the SSRIs have weird withdrawal symptoms where people get ringing or zapping sounds in their ears, but the relative safety and the relatively few side effects of SSRIs make them a far better choice for depressed patients rather than going with the MAOIs or the TCAs. Now you might have to ask, why do they even have MAOIs anymore if SSRIs are so much better? And that's because some patients don't respond to the SSRIs, and you have to try them on lots and lots of different drugs. If a patient isn't responding to anything and the only thing that works for them is MAOIs, then that's what you use. And there's enough people with depression in the United States and other countries that you will see patients on MAOIs and these other drugs. Okay. Now, SSRIs selectively inhibit the reuptake of serotonin. That means if you get too much of that drug, you can have too much serotonin and you get serotonin toxicity. That can also happen when you have an SSRI in combination with another drug that also stimulates serotonin. Serotonin syndrome is the term for serotonin toxicity, and the symptoms include confusion, fever, tremor, seizures, coma, and death. It can also have rises in temperature. And because of the rising temperature, it can sometimes look a little bit like neuroleptic malignant syndrome or malignant hyperthermia, except that in the case of serotonin syndrome, the dantrolene won't work. So, a little side there. And then just to mention a couple of atypical antidepressants. So these are antidepressants that are not MAOIs, TCAs, or SSRIs. There's one class of drugs called SSNRIs. SSNRIs are selective serotonin and norepinephrine reuptake inhibitors. And so they increase serotonin and norepinephrine. A great example of them is Effexor. Now, Effexor is used for depression. I actually take Effexor for my vestibular migraine in addition to the nortriptyline. Effexor is also weirdly good for menopause symptoms. Like, who knows? Effexor is also famous because, at least amongst the internet, because the withdrawal from Effexor is incredibly unpleasant. And so in order to avoid the withdrawal symptoms, which is a lot of nausea and vomiting, you have to taper the dose very slowly. So in the case of the SSRIs, the SSNRIs, tapering the dose isn't so much because you're trying to save the patient's life. It's just to help it so that it isn't so miserable as they withdraw from the drug. Some examples of SSNRIs would be venlafaxine, which is Effexor, as well as duloxetine, which is Cymbalta. There's also a newer drug out called Brintellix, and the generic name, as I have to look, is vortioxetine, for which the mechanism is not as clear, although I've read that a lot of people think it's also an SSNRI. That's the mechanism of action of those. Indirect or direct acting? Indirect acting, right? Okay. Another atypical antidepressant is bupropion, or trade name Wellbutrin. This drug's interesting because it's also marketed under the name Zyban. It seems to help people quit smoking. Again, CNS sometimes doesn't make any sense. Another interesting thing about bupropion is I have a friend who's a psychiatrist who told me that some of the best gifts that he's gotten from patients have been from the partners of patients that he put on Wellbutrin, because Wellbutrin actually increases libido, sexual appetite. So, you know, it's a win-win for everybody. If the patient's libido goes up and their mood improves. The partners really like that. Okay. All right, let's switch to talking about drugs for mania. Now, again, if you think about the monoamine hypothesis, then mania is where there's too much norepinephrine, serotonin, as opposed to too little. Patients that suffer from bipolar disorder cycle between depressive lows and manic highs. Some patients, they can cycle slowly over the course of years or months or days or hours, right? So you can imagine the cycling is very distressing for the patient. In the depressed state, the patient has all the symptoms of depression, and when manic, they have the symptoms of manic. You might think that mania would be something that would be a good thing to have because you'd get a lot done. The problem, again, with any of these disorders is not, that patients, everybody feels depressed sometimes. Everybody feels super happy sometimes. That's not the issue. The issue is when those behaviors actually interrupt the patient's ability to function and to interact socially and have a job and all that. All right. So, for example, I had a patient when I was a medical student. It was a woman who was hospitalized for mania. And one day we come in, she's yelling, she's on the phone on the floor, and she's screaming and swearing into this phone. She slams the phone down and comes out, and she starts swearing, talking about her her husband, about how he's so terrible because he took custody of their children. The reason she'd been in the hospital was because she'd been in the car with her two little kids. One was a baby, one was a toddler, and a guy drove up next to them, like at a stoplight, and she decided that he was cute or something, I don't know. She gets out of the car, knocks on the window, says, "Hey, baby, let's go off together." They drive off, and she leaves her car in the intersection with the key going. The car's running with her two kids. She just drove away because it seemed like a good idea. So that's not fun. I mean, that's probably fun, but ultimately destroyed her ability to have custody of her children. Similar kinds of behaviors can be things like having sex with a football team, or spending all your money, buying all your friends' cars, just feeling great about everything, not really thinking about consequences, to the point where when the patient comes off of the high and back down into low, their life can be completely devastated by what's happened. So that Charlie Sheen interview is a really good example of somebody who's actively manic. And you can see how his behavior is really very bad for him. And fortunately for him, he has this cadre of people and handlers and people around him that are keeping him going. But if he were just an average guy on the street, I don't think he would not be in the financial situation he's in now, much less any other good situation. Anyway, so let's talking about drugs for mania and bipolar disorder. Really, the aim here is to blunt the highs and to blunt the lows. Because if you have a patient who's bipolar and they're depressed and you give them an antidepressant to increase their serotonin and norepinephrine levels, you can make them manic. And that's not good. So it's a tricky situation. The most commonly used drug for mania is lithium. Now, lithium is just the atom that's on the periodic chart, and it's excreted from the body like sodium. And lithium, because it's excreted the same way sodium is, it is not excreted well when a patient is dehydrated, right? Because when you're dehydrated, your body holds on to water, and the way your body holds on to water, at least from the kidney's point of view, is to hold on to sodium, because water follows sodium. So if a patient's dehydrated, they're taking lithium, their lithium levels can go up. Now, you can be dehydrated for a variety of reasons, but if you're dehydrated because you're vomiting, because you ate some bad ham or something, or if you're dehydrated because you had terrible diarrhea, that's going to bring on the lithium toxicity. And then the lithium toxicity side effects, the effects of toxicity are that you get nauseous and vomit. So then you are nauseated and you vomit more and you get more and more dehydrated, and it's sort of really bad vicious circle. So in a patient who is taking lithium, you must instruct them that they have to be sure that they're getting enough fluids. You don't want them to be dehydrated. Now, when I was a student, you didn't have to warn people to get enough salt because everybody ate tons of salt. Nowadays, you have some people that are so worried about their health that they're like not getting enough sodium. You do need some sodium, so you might need to talk to the patient about their diet, and if they're in a salt-restricted diet, to sort of give them counseling about how much sodium they do need to have in their diet in order to avoid lithium toxicity. Lithium toxicity is mainly to the kidneys, also to the heart. Other drugs that are used for mania include mood stabilizers that are actually anti-seizure drugs. We mentioned a couple that are used, like carbamazepine or Tegretol is the trade name for that, or valproic acid or Depakote. We talked about those when we talked about seizures. Other drugs used for mania include some of the atypical antipsychotics. I'm only going to ask you guys to memorize for me the two, olanzapine, which is Zyprexa, and Abilify, which is my favorite drug name of all time, because you take it and then you're abled. You are become abled, so you're abilified. I love that name. The nice thing about olanzapine is that if you have a patient who is already on lithium and you start them on olanzapine, you don't have to necessarily adjust their lithium dose. So I should have mentioned, lithium has a very low therapeutic index. And so just like any other drug with a low therapeutic index, patient's going to have blood levels checked because high levels aren't good for the patient. All right, anything else? Is that it? All right, next stop, antipsychotics.